Hi, everyone. Welcome back to CHR's Real Life, Real Hope podcast. I'm Maureen McGuire, Senior Vice President of Advancement at CHR. And we are joined once again today by Dr. Brittany Liebla. She is the Addiction Medicine Specialist for the Medication for Opioid Use Disorder program at CHR. Welcome back, Brittany.
Thank you.
You're listening to the Real Life, Real Hope podcast, brought to you by CHR.
So in our previous episode, we talked about the outpatient treatments through CHR's Pathway program. So maybe as a reminder, you can talk a little bit about Pathways, and I know we also want to touch upon harm reduction.
Sure. So Pathways is our opioid treatment program or methadone clinic, and there we provide comprehensive care for opioid use disorder treatment, as well as other substance use disorders. We provide therapy, one-on-one therapists and counselors. We provide a recovery support specialist, someone with lived experience. We try to meet all psychosocial needs, and that might be housing, insurance, transportation, whatever it is. We try to meet the patient where they're at and really help them meet their individualized goals. One unique thing about our Pathways program is we were the first OTP within the state to incorporate a harm reduction supply. So what that means is where patients can go to Hartford or other areas in Connecticut to get safe needles, we've actually incorporated that within our OTP. So by embedding that, we can really engage patients and build a rapport, even if they're pre-contemplative about quitting their use, and give them the safest route. So we provide needles, crack pipes, wound care, safe sex kits, whatever it is that patient needs at that time. And we know by doing that, we can actually reduce HIV and hepatitis by about 50% in prevalence. So really giving a safe supply and then progressing from there.
So this ties back to what we were discussing previously about CHR's philosophy of really meeting people where they are.
Yes.
And if they're not ready to really begin treatments, they can begin a relationship with CHR to at least keep them safe until they are ready.
We always have something to offer, no matter where you are in that trajectory of quitting.
Because it's a big lifetime.
If it was easy, this wouldn't exist.
Yeah.
We wouldn't have an
Exactly.
opioid crisis.
Right.
Yeah.
Right. And also we talked previously about the prevalence of opioid use in Connecticut, and you had some great statistics. If you could just repeat that about where Connecticut is nationally.
Yeah. So according to the CDC, Connecticut ranks 8th overall in states with the worst overdose death rate.
For a small state, that's a powerful
Absolutely.
stat. So along with your work at Pathways, you're involved with some really interesting work that CHR is doing in the community.
Yes.
Can you tell us about your role with the Department of Correction?
Yes. So the Department of Corrections is such a novel way to look at opioid use disorder treatment. There, I was designated as the primary medical provider during the integration and expansion of all 3 FDA-approved medications within Connecticut jails and prisons. So we know that Rhode Island was the first state to incorporate all 3 FDA-approved medications, which are methadone, buprenorphine, and naltrexone. And when they incorporated those back in 2016, the next year they showed a 61% reduction in overdose death rates.
Wow.
So we are also trying to mimic that and promote, that reduction in overdose death rates in our own town and state. In 2019, before this project started, we showed that about 50 to 55% of our overdose deaths were consistently former inmates.
Wow.
So the need is there. We just have an ethical obligation to treat these patients.
50% among people who were like newly released from prison? Or?
So throughout the year, it was 50 to 55% of the overdoses were former inmates.
Wow.
Yeah. And we know
That's
that
staggering.
North Carolina did a study showing that inmates within the first 2 weeks post-incarceration, when they're released, they're 40 times more likely to die of an overdose death. That rate stays elevated to about 9 times the general population, even a year after their release.
Wow.
So they are just so disadvantaged. There's such stigma there. We have that ethical obligation to treat a preventable known cause of death, and we can. It just makes sense to stabilize these patients before they're released, before they're going home to an environment with environmental triggers. That risk of relapse is so high. So stabilizing them, getting their cravings under control really just makes sense.
Wow. Yeah, that is incredibly important.
Yeah.
And does CHR also help individuals to plan for their reentry into the community? So I understand you're providing the care while people are incarcerated, but what happens when they're...
So we have a designated reentry coordinator, actually, and they will meet with the patient one-on-one when their release plan is finalized, and they'll set up the appointment. They'll set up any of those intricacies to get them to treatment. So that discharge is really seamless. We want them in treatment same day, next day, without any kind of lapse in their prescription.
That's great because, as we talked previously, this is, it's a long-term path to recovery.
Yeah.
That's great.
And while they're there, they're also working through groups and therapy. They have the DOC side where their addiction services is doing their own therapy services, and CHR also comes in. So they're getting the best of both worlds.
That's fantastic.
Yeah.
What's been the most rewarding part about your role with DOC?
It's such a challenging environment to work in. But what I find really devastating is patients will come up to us and say, we're the only one that has treated them like a human being. And that's just so sad. We know that there's a level of trauma that people endure when they are incarcerated. So trying to kind of lighten that in any way is so rewarding. I also like the challenge of reducing the stigma. There's always a conversation on why we're doing this, the benefits of it, and any chance I can get to kind of just reduce the stigma overall in opioid use disorder treatment is a benefit for me.
That's great. That's great. Just want to switch gears to another community program. So you were one of the leading forces behind a new pilot program, which is with CHR and the Summers Fire Department paramedics.
Yes.
Can you tell us a little bit about that?
Yes. So I reached out to the Summers Fire Department. I knew them through my previous work in the emergency department because as an addiction medicine specialist, it's been very difficult to initiate Suboxone. That is one of our life-saving treatments for opioid use disorder. It's a film that goes under the tongue. Patients take it once, twice, maybe 3 times a day, reduces cravings, alleviates withdrawal symptoms, and helps provide patients that stable lifestyle. The problem is you need to be in a moderate amount of withdrawal in order to start the Suboxone. And that's very difficult for patients.
The timing.
Yeah. They can't tolerate withdrawal from fentanyl. It's so potent. And that withdrawal feels so much like death to people that we're really struggling to start it in the outpatient setting. So by providing Suboxone administered by paramedics after an overdose, after they receive Narcan, they're already in withdrawal. There's multiple benefits. It treats their withdrawal symptoms in a humane way. It links them to treatment. It initiates treatment, and they're able to start the Suboxone, and then they get same day or next day access with us.
Because time is so critical.
Right.
So you don't run the risk of someone having an overdose, being treated, but then potentially having another overdose.
It can protect them against overdose, ideally for about 16 to 24 hours. So by, reducing those cravings and blocking that opioid receptor, we hope to have better outcomes.
And then within that window to get them into ongoing treatment.
Yes.
That's a fantastic model.
Yeah.
It makes so much sense.
Yeah. It's the first in New England. The closest was in Camden, New Jersey. And there were other programs that we also mimicked this after: California, Philadelphia, but nothing really close. So it's very exciting.
And it also really speaks to the importance of working with community partners to try to improve care for individuals with opioid use disorder.
And collaboration is everything.
Yeah.
We know Enfield EMS has also taken on this project.
Oh, great.
Yeah. So big things are coming.
That's wonderful.
Yeah.
Great. Thank you.
You're welcome.
This podcast is brought to you proudly by CHR, where real life meets real hope. Visit chrhealth.org to explore resources and services. Be sure to like and subscribe wherever you get your podcasts. Please rate and review and join the conversation on social media.